Welcome to Health Focus. I'm your host, Dr. Scott. November is Lung Cancer Awareness Month. Cancer has surpassed heart disease as the #1 cause of death in at least 22 states, including California. Unfortunately, lung cancer remains high on the list of conditions leading to cancer-related death. Today, we're very fortunate to have with us an expert on lung cancer. I'd like to welcome Dr. Jonathan Lopez to the set. It's a pleasure to have you here.
Nice to meet you, Dr. Scott. Thank you for having me.
It's an honor to have you here, and I know that you're an oncologist in the community. Maybe you could start by telling us a little bit about how you got into the medical field and oncology, the treatment of cancer in particular.
Well, I joined the Air Force without any college at all, and I was a pharmacy tech, and I started learning about medicine in the Air Force, and my career path actually led me to medical school through the Air Force. They trained me. I did all my training at Wilford Hall in San Antonio, Texas.
I was at Wilford Hall also being a physician. When were you there?
I was there from 1994 to 1998.
Okay, I left in '93. I was a
just
rheumatologist. Yeah, too bad. And then did you do a fellowship in the Air Force or subsequent?
Did a fellowship in the Air Force right there at Wilford Hall as well.
Fantastic.
And my first assignment was at David Grant here at Travis Air Force Base.
Okay. And do you practice general oncology, or do you have a particular interest within cancer as a field of endeavor?
General oncology. I like to see the whole breadth of medical care. We treat the top cancers, of course, breast cancer, lung cancer, prostate cancer. That's what we specialize in, but we see everything.
I understand that, in fact, in terms of the listing of cancer caused deaths, that for women, breast is #1, I believe, followed by lung cancer, and I think in men, lung cancer is #1. Is that correct?
Well, that's changed a few years ago, where breast cancer exceeded lung cancer in female deaths. But now lung cancer has exceeded breast cancer, actually by about twice as many deaths. We're getting, overall the rates of cancer deaths are going down, but we haven't become as advanced in lung cancer as we have in breast cancer. With earlier detection and better treatments for breast cancer, the death rates have gone down. We just don't have the early diagnosis that we'd like in lung cancer yet, although we're getting there.
You know, that's very interesting, Dr. Lopez, because, you know, we think about cancer deaths as being a #1 cause of death, but in fact, both heart disease and cancer deaths have declined significantly. I believe that the rate of heart disease has simply declined faster, so that cancer is left as the #1 cause of death, even though we're doing better in treating cancer.
Correct. In fact, if we live longer, because of mutational errors in our body, we're more apt to get cancer. Now, it's interesting, though, that women have a higher incidence of dying of cancer, of heart disease later in their lives, but their incidence of dying of cancer in the middle of their life, from their 40s to their 60s, is higher. So that's the cancers we want to catch in women, and in men, it's getting to be cancer as the top killer.
Right, and of course we're focusing on lung cancer, and November is Lung Cancer Awareness Month, and the incidence of cancer actually has lagged behind smoking as a leading indicator, has it not, since the 1960s?
It has. It seems to be about 1965 is when the incidence of smoking peaked, but the lag for cancers 30 years later is when we saw the peak of lung cancer-related illness. And lung cancer is one of those diseases that if you have it, you'll tell your family about it, and we know about that. But there are many other factors of smoking, such as lung disease that keeps people from breathing well, COPD, and so there are many other things that if you don't get lung cancer, you might get COPD that causes life problems in smokers.
So let's talk about smoking. My understanding is that about 85% of lung cancers overall, at least, are caused by smoking, or at least associated with smoking.
Correct, 85 to 90%.
85 to 90%. The rate may be lower in women, although some data suggests that that may be a reflection of women who don't smoke being exposed to secondhand smoke. I know that's been, for example, noted in other cultures. It's been noted in Taiwan. What is your experience with respect to the relationship between smoking and lung cancer, both in men and in women?
Sure. So on average, women smoke less. The incidence of smoking in women is less than in men. And interesting side note that when somebody finds a partner that they feel like they're going to spend the rest of their life with, and they marry, if someone started out as a smoker and the other was a non-smoker, they've accepted that in the relationship and they'll allow that to go on, as opposed to binge drinking or maybe illicit drugs or those things. Typically for binge drinking and illicit drugs, the partner will stop that, but they won't typically stop smoking. So the spouse, in this case typically the non-smoker, would be exposed to second-hand smoke, and their incidence of lung cancer goes up from that. So, and if you have two smokers in the house, it's very difficult for both of them to quit unless they both quit together. When I have patients who come in and one of the spouses has lung cancer, and the other spouse says, "How can we quit?" I said, "You need to quit together. What I want you to do is, for every dollar or the cost of a pack of cigarettes, I want you to put that in a jar. And every day that you've quit smoking, you put that money in a jar. You put that money in a jar. If somebody starts smoking, well, then you get the money in the jar. And if after 6 months, neither of you have smoked, you've built up enough money in that jar to go on a nice vacation."
Absolutely.
So it's a goal-driven therapy, and there's a little competition in most people. So
Right.
that's a way to quit with your partner at the same time.
Right. I know that Stanton Glantz at UC San Francisco, who's devoted his career to smoking, has made some recommendations that I've heard from him in talks about how to quit. And in addition to both partners quitting, he also, I believe, has suggested possibly changing to a different brand of cigarettes, the idea being that there may be compounds that are addictive in cigarettes other than just the nicotine. I don't know that there's scientific data to support that, but have you found that to be helpful?
Anything we can do to help people stop smoking now. I have not tried that
Right.
specifically, but if I'm willing to give it a shot if that's what would help somebody stop smoking. It's a difficult problem. It's a tough addiction to crack.
Some have said that it's harder than heroin.
They have.
And of course, not only is there the addiction, but there's a social component to it. And as you said, if your partner doesn't quit, it could be extraordinarily difficult. Before we get off of the subject, though, of secondhand smoke, some people have described so-called side stream smoke. Can you explain what that is?
So when a smoker actually inhales on the filtered end of the cigarette, they're getting the mainstream smoke. And there are many toxins there. In fact, there's nearly 7,000 toxins within mainstream smoke. Not all of them cause cancer, but a lot of them cause harm. And there's about just greater than 70 known carcinogens in cigarette smoke. Now, that's filtered and it's highly burned tobacco. But the side stream smoke is the smoke you see coming off of the end of the cigarette. And that has 5 times more toxins than the mainstream smoke. So if you're sitting in a car and you're smoking and you have a child in the back seat, they're being exposed to 5 times the toxins that you are by inhaling.
Right, that's very interesting because it points out also that, for example, when an individual is smoking, those around the individual are being exposed to the smoke. We pointed that out with spouses. But I often wonder about that with respect to, for example, cigar smoking. Because theoretically, cigar smoking in many people involves just inhaling into the mouth and so forth. However, the cigar smoker is exhaling into the environment.
Correct.
So not only is the cigar smoker breathing secondhand smoke if the cigar smoker is smoking inside, but everyone around the cigar smoker is also smoking. I know Fidel Castro, who was a famous cigar smoker at one point, I believe, developed, if I'm not mistaken, a lung cancer and quit smoking before he died. But how dangerous are cigars compared to cigarettes? That's kind of what I'm leading up to.
Sure. Well, cigars, they are linked to lung cancer, but it's a lower rate in that people aren't smoking as many cigars for as long as they do, say, a pack of cigarettes. Although they do hold the smoke in their mouth, so their incidence of head and neck cancers goes up with cigar smoking. And because the cigars are loosely wrapped, they're more likely getting some side stream smoke through the center of the cigar increasing the toxins. And the cigars are aged and they're fermented, so we're having some formaldehyde, which is a known carcinogen.
So as an oncologist, you discourage all smoking, I imagine.
I do. If we're going to put something burned into our lungs, that's not natural, and it's likely going to lead to some mutations.
You know, that's an excellent segue to discuss cannabis or marijuana because, you know, this is obviously an area in which people have strong opinions. And many of the advocates for legalizing marijuana state in television and radio forums, I've heard this, I can't give you a specific reference, that no one has ever died of marijuana smoking and that it's not linked to lung cancer. But I find myself skeptical of that, leaving aside the issue of motor vehicle accidents while smoking and so forth. It is another burning plant material. Are we simply lacking in data one way or the other on this, or is there actual data to suggest that marijuana is not linked to lung cancer? Can you please explain that to us?
That's a very difficult thing to prove, in that cannabis is a Schedule I narcotic. So in the United States, we can't do research on cannabis unless you're in a very controlled setting. They do have some research coming out of Europe that suggests there's a link between smoking cannabis and cancer. But there's also an association with people who smoke cannabis also smoke tobacco. So are we able to tease that out? But again, if you have burned carcinogens that are being inhaled into the lungs, there's a risk for cancer with that. Smokers of cannabis don't smoke as much cannabis as they do cigarettes. So if you smoke less, you have a less risk for cancer, but it's still there. It's not zero.
And of course, advocates for so-called medical marijuana have also pointed out that you can, for example, consume some of the active compounds in marijuana as edible objects and even as vapors of various types. However, that leads me to a related topic, which is, of course, highly contentious, and that is vaping as opposed to smoking. Now, maybe you can first explain kind of what this is all about. What does it mean to vape? What exactly does it mean? For example, a famous proprietary device is called Juul. Okay, what are these devices? How do they work? And what do you think in terms of lung cancer in these devices?
Well, so far, since vaping or vaporizing the liquid form of nicotine and inhaling that, it does take out some of the carcinogens within a cigarette. But what we're doing is we're swapping one nicotine delivery system for another. And in fact, vaping pen, the acronym for it is Electronic Nicotine Device System, and the acronym is ENDS. And I think, well, it can be the ends if you do that too much.
Right.
So I think in 10 years, maybe, as you know, the lag for the peak of smoking and the incidence of lung cancer was 30 years, we might know more in 30 years.
Right. And of course, there are competing models in terms of medical advice and epidemiology about a question such as this. For example, many British authors, I believe, in their medical literature have embraced vaping as a kind of harm reduction, as it were. In this country, however, I know concern has been expressed that particularly in younger people, the use of vaping devices might be a gateway to cigarette smoking.
Sure, or a gateway to other pharmaceuticals. I always find it interesting that people will find all natural everything, but yet still smoke.
Yeah, indeed, there are people who smoke cigarettes and suggest that they have an all-natural brand. I've encountered patients who have said that.
If it's all natural.
Yeah, it's all natural. Now, of course, we know that some lung cancers do occur in people who don't smoke. We discussed secondhand cigarette smoke, but there are other factors as well. We are bombarded by some electromagnetic radiation from outer space.
Correct.
That's greater if you go up at altitude in an airplane. And then you can buy testing devices for radon gas.
Radon.
So, and there's asbestos, which is linked primarily to mesothelioma, but it's also linked to lung cancer. Mesothelioma being the cancer of the tissue surrounding the lung. So, could you enlighten us a little bit, JD, about non-smoking related risk factors for lung cancer?
Sure, and if you're exposed to radon, and they have radon detectors, especially in the east where people have basements and the radon can collect, their risk for lung cancer does go up. And they recommend that you put a radon detector in your basement to see if you're at risk. But unless there is, pardon the pun, a smoking gun, we usually don't find the cause for those non-smoking associated lung cancers. Mesothelioma, on the other hand, if you've been exposed to asbestos and you're a smoker, and you can develop mesothelioma and adenocarcinoma of the lung is the most common.
And I suppose probably the most famous example of that would be Steve McQueen, the action movie star who was a fantastic actor who succumbed to mesothelioma, I believe, at age 50. And he had been exposed to asbestos in the Navy, and he was also a heavy smoker.
Right, so shipyard workers, anybody in the Navy or merchant marines years ago.
And of course there are different types of asbestos. There's friable asbestos, which insulates pipes, which really gets into the lungs. And then asbestos could also be hidden in firewalls and tiles, in which case it typically is not as harmful.
It's not going to be aerosolized, exactly. You know, the one form of asbestos that is common, and we wouldn't realize there was in our own homes, is the popcorn ceilings that you find in 70s styles home. But you can actually, if you can safely scrape some off and send it off for testing, they'll tell you if you have asbestos ceilings or not.
I've encountered that when I was involved in working in the state prison system. Some of our offices were in fact older cells that had been converted to offices, and a few of them had tile ceilings that were covered with mold which had eaten into them, and the material was sort of falling down on us. So that did cross our minds, I can assure you. How about air pollution in general? Do you think that this is something that is improving? On the one hand, emission controls are stricter. On the other hand, for example, in California, our population, since you and I were kids, has probably tripled. So, and we have less indoor secondhand smoke. Obviously, that's a great advance.
Right, right.
But how about air pollution as a risk factor for lung cancer in non-smokers? That's
yeah. So, if you're in a major city or in a city that has a lot of air pollution, that's equivalent to smoking 1 to 2 cigarettes a day. So, if you go for your run on a heavy pollution day, a heavy air index day, it's like smoking an extra cigarette.
Are there genetic factors, for example, family history, that are significant with respect to lung cancer?
There are, and the question that we have to ask, is that related to the prior exposure to secondhand smoke, or is it that there's a genetic component? And we haven't teased out the genetic components. We're leaning towards some, but there's no definitive. Like there is in breast, we know that the breast and ovarian cancer gene increases the risk for breast cancer and ovarian cancer. We don't have just one single genetic mutation that we can say your risk for lung cancer is tripled.
So you're referring to, I believe, BRCA1,
correct,
BRCA2. And in lung cancer, there has been research done on a few potential genes or proto-oncogenes, not to get too much into the weeds, related to cancer. One I think is called KRAS. The other is called EML4 ALK tyrosine kinase fusion gene, which is hard to say fast. But we're not there yet. We don't have anything like the genes associated with breast or ovarian.
Not yet, although this is very interesting in screening. There's some targeted therapy using different mutations in treatment, but in screening, that's where we really need to make some advances, because the incidence of death from breast cancer has gone down because we have earlier detection. If we can detect cancer at an earlier stage, when it's smaller and potentially curable, then people live longer with a decreased incidence.
So if someone comes into your office with weight loss or chest pain or coughing up blood, our time is actually becoming a bit short, but tell us briefly, how do you evaluate them as an oncologist? What's the process?
If my suspicion was that they had lung cancer or cancer in general,
Yes.
I would have them do a CT scan of their chest or any part that was causing them pain. And if I saw a mass, depending on the size of the mass, we would likely perform a biopsy, where we would put a needle into that area, whether it's in the lung or in a bone, and look at that under the microscope and test it for different mutations.
And then I know you go through a sophisticated process called staging to see if the cancer is spread.
Correct.
And the survival is still pretty grim for lung cancer in spite of improvements, is it not?
It really is. Unless we catch it early, and we typically don't, because lung cancer doesn't cause a lot of symptoms. By the time it's causing shortness of breath or coughing up blood, it's usually fairly advanced. When it starts causing pains in the bones, it's typically fairly advanced. The lungs are a very spongy organ in the body. They can take a lot of growth of a cancer before we have any symptoms at all.
Could you tell us just in sort of simple terms, not simple but less than the arcane language that we use in medicine, the different kinds of lung cancers and overall categories? There's more than one type.
There definitely are. But we can split them into two easy categories. Small cell, which is a very aggressive cancer that needs to be treated in weeks. And non-small cell, which is also a significant cancer, and actually the majority of cancers are non-small cell, but we have many more advances in non-small cell. And in non-small cell, you can split that up into two groups, squamous cell and non-squamous cell. Years ago, we used to talk about large cell, but we lumped that in with the adenocarcinoma. And even now, we're starting to treat them more the same with our new immunotherapies. And that's an exciting new field that's caused some very, very good responses.
And some of these are actually advertised in direct marketing to consumers on television. So tell us overall, without getting into any proprietary issues specifically, what is new in the treatment? What are these immunotherapies, and are they promising?
The immunotherapies are very promising. I've seen some of the latest data that shows improvement in overall survival. That means lengthening somebody's life when compared to not using these latest therapies. Now, here's a very good advance. In those non-smokers, if we test for a specific marker, we can give them a pill that they can take if it's positive for that marker. They take a pill once a day, every day, and their survival is longer than maybe a smoker who does not have that mutation. So looking at the genes and the mutations within the cell is essential for our treatment. Now, about a year ago, we tested for a specific overexpression of a gene in our lung cancer patients, and if you had that overexpression, we would give immunotherapy. But now we're finding that with combination chemotherapy and immunotherapy, even if you don't have the overexpression of that protein, you would benefit from immune therapy.
How about radiation therapy?
We use radiation therapy in earlier stage lung cancers after surgery, or maybe even before surgery, to try to to shrink the tumor so we can proceed to a potentially curative intent treatment.
It must be a fantastic feeling when you cure lung cancer.
It is. It is. I wish we had it more often because, again, it shows up usually advanced, and that leads to screening. And right now, our screening test that almost all colleges are accepting as the standard, which is the low-dose CT scan. A chest CT scan without contrast, it takes about 25 seconds to do. The drawback is that it's not widespread. You need to live in a community that has a low-dose CT scanner, so we can find these at the earliest of stage when we can cure them with surgery.
Do you have any advice for our viewers on how to prevent lung cancer?
Don't smoke. If you smoke, quit. If you know somebody who smokes, encourage them to quit.
Does chewing tobacco cause lung cancer?
It usually causes head and neck cancer, esophageal cancer, but not typically lung cancer.
Okay. And our guests may want to, our viewers may want to get more information. What do you advise your patients in terms of resources that might be of help to them in learning more about lung cancer, either if they have received the diagnosis or if they're concerned about it?
There's a very credible site that I go to as a physician standpoint. It's called NCCN, nccn.org. Wonderful site, has a lot of good information for both the physicians and the patients. You can go there to find any kind of information on really any cancer.
I understand that North Bay also does a lot of community outreach and education, and
We
they do
do.
have forums.
We do. We have a lot. In fact, we just had a forum this past week.
Are these forums that involve primarily oncologists or surgeons or different specialists?
They'll vary throughout the year, but we have an oncologist at least once a year talking about breast cancer. We just had a genetics discussion about the risk for cancer with genetics.
Okay. And JD, are you optimistic about the future with respect to lung cancer?
I am. I'm optimistic about the future in regards to all cancers. Our diagnosis, our treatments are getting better. They're getting easier to tolerate. And if we can encourage people to stop smoking, if we can encourage people to get early screening in breast cancer, colon cancer, and even lung cancer, then our death rates will go down.
Let's hope for that, and thank you so much for joining us.
Well, thanks for having me.
Thanks for all you do for the community and all that you and your colleagues do at North Bay to assist the community, and I believe you're also on faculty at Touro University. It's really been a pleasure having you on the show. It's a tough topic, but I'm left with a sense of cautious optimism, and I hope that our viewers will be left with that, because remember, at Health Focus, we focus on your health. We hope that this has been a useful hour for you as we look forward to continuing activity in cancer prevention, particularly in Lung Cancer Prevention Month. It's been a pleasure having this distinguished guest and being with you here on Health Focus. Until next time, this is Dr. Scott saying stay healthy.